We have our last lecture of the CME now by Dr. Vikram Mathews, Director, Christian Medical College, Vellore. His topic is Leukemia and Stem Cell Therapy Updates. I would like to give a short introduction of Dr. Vikram Mathews. Dr. Vikram Mathews has done his MD in medicine from Christian Medical College, Vellore in 1996. Then he did his DM in clinical hematology from CMC Vellore in 2001. He is the first DM student in hematology in India. He was a postdoctoral fellow at the Stem Cell Biology section in Department of Internal Medicine, Washington University, St. Louis, USA in June 2003. He did his fellowship in bone marrow transplantation at Washington University, St. Louis, USA in May 2004. Currently, Dr. Vikram Mathews is the director of the prestigious Christian Medical College, Vellore. He is involved in publications of more than 200 manuscripts and 5 textbook chapters. He is a reviewer of more than 14 international journals and associate editor of PLOS ONE and British Journal of Haematology. His special interest is in myeloid malignancies and stem cell therapy. Ladies and gentlemen, presenting before you Dr. Vikram Mathews.
Thank you for that generous introduction. Thank you, Bhumi and Sandeep, for inviting me, and congratulations. Nothing makes a teacher more happy than to see his students succeed and do so well. And they have really done us proud. They're all diamonds in their own, but they came a little raw to us. We've taken them through a process of pretty intense polishing and a little bit of breaking down and polishing, and their work speaks for itself. They've really done well for themselves. So congratulations to all of you all. Many students pass through us, but one thing that strikes me about all my students sitting over here today, and including Bhumi and Gautami, who I do not work too much directly with, they were incredibly hardworking, and it's not at all surprising that they're all doing so well. And also, when you talk, and I come and give a talk like this, and I talk about numbers in CMC, it's different. The challenges and the situations in which they are working individually is much more challenging. So I'm always amazed at what they're able to do as individuals in a smaller center with much lesser support. So congratulations to all of you all. And CMC's motto has always been excellence in education, service, and research, and you all have done us proud. In that whole exercise, we also stress in our teaching compassion and care for patients, and that's something that they have always shown, and also make it a conscious effort to make sure that these therapies and this God-given gifts of yours are also accessible to the poor and marginalized in society. With that, I'll start on my talk on hematopoietic stem cell transplantation. The concept in a hematopoietic cell transplantation is fairly straightforward and simple. It's almost like giving a kidney transplant or a liver transplant. You have a problem with the hematopoietic stem cells, which is like, if you imagine it like an organ, and that could be either, it could be inherited or it could be acquired. So inherited would be a disease like thalassemia. Acquired will be an example like leukemia. So basically, if you can imagine, you can take out that system and introduce a new system, and then you can essentially cure the patient. That's the fundamental principle. It's easy to say, but there are many challenges. And these stem cells, when you replace it, will go and produce all the elements that form the normal blood cells. Now, the stem cells have to be, to do that, there are certain procedures that we have to take a person through allogeneic transplantation. And the first barrier that came about in transplanting is HLA barrier. So imagine if you were to infuse blood from me to anybody else who is the same blood group and cross-match, what happens to the white cells that are there in that blood? They don't survive more than a few minutes. The immune system of the recipient will immediately destroy those white cells. So it's very difficult to infuse nucleated cells across a HLA barrier because your immune system will destroy them. So why are the red cells not destroyed by the immune system? Because non-nucleated cells like red cells don't express HLA molecules on their surface. Okay, so that's a very fundamental basic concept. HLA is located on chromosome 6, and you have 2 pairs. Like all chromosomes, there's 2 alleles are there, and the entire HLA is inherited as a block. So you imagine if the father is AB and the mother is CD, the children can be a combination of the father and mother in those combinations. And so for every child that you have, so say for the first child from this parent is AD, what is the chance that the next child that they have will also be that exact combination of AD is 1 in 4. Okay, just conventional Mendelian inheritance. So if you have more children, every child, the chance is always 1 in 4. You understand? It's like throwing a dice, it's always a 1 in 4. But in reality, when you have many children, the probability that you're able to throw the dice more often to get that match increases. And therefore, there's a statistical calculation for that. If you have more children, your chance actually increases. It's not just 1 in 4. If you have 6 children, for example, you have almost an 82% chance that at least one of them will be HLA identical to you. But every single individual, if I take and say, what is the probability that this individual is matched to this patient? It's about 1 in 4. So the basic principles of transplant are highlighted in this slide. You have a recipient who has a problem, which could be inherited or acquired, as I mentioned to you. You have a donor who is shown in red over here, who is healthy. And before you can take his stem cells and infuse it into the recipient, you have to take the recipient through a process to accept these cells. As I told you, the immune system is likely to destroy the cells that are going to come in. So you use drugs called conditioning regimen, which is usually drugs or radiation, or you use there are different types of regimens that you can use to prepare the patient to receive the donor cells. That's called conditioning regimen. And after you infuse the cells, usually the stem cells will engraft and produce all the normal cells. Unfortunately, sometimes some of these complications are unpredictable. In spite of everything being correct, the cells won't engraft. Or sometimes the cells will engraft, but they will react very aggressively against the recipient and call a condition called graft versus host disease. And the challenge for transplanters is many of these things are not very accurately predictable. The stem cells that we collect from the donor can come from the bone marrow, peripheral blood stem cell, or cord blood, which we don't usually use. You can have a donor which will usually be a brother or a sister if they are fully matched. But if you don't have a brother or a sister, it could be a matched, unrelated donor. That means anybody in the world who randomly is HLA matched with you. That's called a matched, unrelated donor. Which is why wherever we go, we talk, we tell people, register onto these donor registries. And many of you all may have come across DA3, DKMS in India. And there we have one person who puts up his hand and says he's a donor, he's registered. Register on it, because the more people register, by random there'll be some child with leukemia, somebody with thalassemia somewhere who you will match and you can donate. And remember, donating stem cells is not like donating a kidney or an organ. Your body will immediately remake this. It's almost like donating a unit of blood. And it's the best service that you can do. I am registered with DKMS. I'm speaking where my mouth is, so I've actually done it. So I encourage all of you to register onto registries and be a donor. There's nothing that you can do better than that. Now, India is a very complicated country, and all these therapies are very expensive. And as many of you all in the medical profession here know, that many people cannot afford these. So we have lots of mechanisms to try and serve these people, but still it remains a challenge. And there are parts of the country where really access to this therapy, especially the middle part of India where you see the greens are actually doing well, the light oranges and reds are not doing well. The multidimensional poverty index in those areas are very high. Okay, so you all sitting here in Sangli and Miraj should be very grateful that you have almost 3 sets of people who can offer you transplant and high-end hematology care. You look at their labs, they're really very good labs that they've set up, and so it's fantastic. And again, I can't appreciate you guys enough for all that you all have done. The healthcare cost in hematology is expensive. I won't go through this in detail. I think all of you all understand it. A matched sibling donor will cost about 14 lakhs, and mud can cost between 35, 40 lakhs, but of course these costs can reduce. So these are expensive procedures when one talks about curative care. This is our old building, the Department of Haematology, where we had about 10 beds inside and 10 beds outside, 8 beds outside. And this is where all these boys over here have trained. I call them boys. They're all big guys now, but they're boys when they trained with us and worked very hard, spent many sleepless nights in their training. They are well trained, that I can assure you. But we moved now to our new campus. This is the Ranipet campus. It's a 1,500 bed hospital. We now have about 100 inpatients in hematology. We have about a 30-bedded transplant program. So we are a very big program right now, and that's the kind of numbers we do a year, about 250 plus allogeneic, 50 to 70 autologous. mud transplants and haplos regularly. And you can see in 2022, for example, we did about 310 transplants. So that's a pretty large program. And this is an excellent program for people to train. So if you train in a program with this kind of volumes and strength, you will be exposed to every single possible and potential complications that can happen, good and bad. I'll talk a little bit about some of the work we do, just to illustrate the kind of work that we do and also to sensitize people on certain issues with some of these diseases, and also talk about some of the recent advances. Thalassemia major, I'm sure this part and many other parts of the country, you see patients with a lot of these hemoglobinopathies. At this point in time, an allogenic transplant remains the only curative option. To risk stratify these patients, we use just 3 simple factors: liver size more than 2 centimeters, presence of liver fibrosis, and inadequate iron chelation. If you have all 3, you're called class 3. If you have none of them, you're called class 1. Class 1 do very well. And what's the unifying factor for class 1? They are young. The younger you transplant them, the greater your success. So for pediatricians sitting in the audience, people sitting in the audience who see thalassemia patients, if you're thinking of a curative procedure, think of it very early. When they are 15, 20, with hepatosplenomegaly, with severe bossing, with all the iron overload, all the complications, you take them for transplant, the risk of complications becomes very high. And so today with transplant, we can achieve more than 90-95% long-term cure in the low-risk patients. In the high-risk patients, it remains a challenge. And for transplant patients, this is some of our observations in our center. These 2 patients, for example, are both high risk by the conventional liver size, inadequate chelation, fibrosis. But for those who are involved in thalassemia and transplants, they will straight away tell you that patient 2 is going to do much worse because he's much older and he's got a huge liver and spleen compared to the first patient. So conventional risk stratifications sometimes are not able to identify risk groups in our population. So this also brings a bigger point why your own data is often so much more important than published Western data. May not have that much relevance. So this is an observation from our center, and today it's well recognized that within the class 3, we have a group called the class 3 high risk, who are more than 7 years and a liver size more than 5 centimeters, who do very badly with transplantation. And for them, multiple other international studies since our publication have verified these observations, so these are not random observations. We have looked at various strategies to try and improve the outcome of those very high-risk patients, and what we have done in our center is use a regimen called triosulfan. It's not a regimen we introduced, it's already there, but we used it specifically for our high-risk group of patients, and today we get very good results with our high-risk group of patients. So if you look at, I'll just take you through one graph. For example, the class 3 high-risk group of patients with our historical control, these were the survival curves. But today with TRIO, we are hitting more than 80-85%, even in the class 3 high-risk group of patients in terms of overall survival. So if you look at our long-term data over decades now, you can see, just to highlight that in spite of the fact that we are doing older and older patients, our overall survival curves are actually statistically significantly improving. Okay, so that's the strength of a large program and a certain confidence that comes with dealing with large numbers. So it's not about individual glory or greatness of one person. Transplant is always a teamwork. It includes very important components are your nurses, your technicians, and they all have to work together to make a program succeed. So I put up these pictures once in a way just to illustrate, with permission. This is a family with a brother and a sister, transplanted more than 15 years or 15 or 17 years ago. You look at them, there's no way you can differentiate which of these 2 children were the thalassemia patient who was transplanted and which was the donor. So when you do this early and you follow up these kids, they look absolutely normal. So it's very gratifying to see them come back. I also want to sensitize you that the Government of India, the Ministry of Health and Family Welfare, through Coal India Limited, using their CSR money, is now supporting children for thalassemia transplants. But you have to be a class 3 low risk or below. They will not support a class 3 high risk. So it's important that you get them less than 12 years of age with early features, and then if you HLA type them, you can refer them to centers for transplant. And many people through this program have benefited from our center. We've done more than 100 transplants on this program for patients, and there's people from all over. I wouldn't be surprised if there's some people from around here. But in all these positivities, I also want to highlight one very important factor that you all must understand, and you all should also support your transplant team and your doctors over here. Mortality is something that is unacceptable but can happen in transplants. And that happens whether you do it in Harvard, whether you do it in Yale, whether you do it in CMC, whether you do it anywhere. And there are factors in that which is just not possible to predict accurately. So in spite of this, we will lose patients. And it's very, very, very hard for us when you take a child who comes in walking to you and then dies post-transplant. The reality is that a small proportion of patients will have fatal complications, and this is where administrators and the rest of the team should support the transplant team. I'll talk a little bit about leukemia and the challenges. Acute myeloid leukemia I'll take because one of the most expensive diseases to treat. For those who are interested and want to read this further, read about our own experience from CMC in British Journal of Haematology in 2015, where we've told you about the challenges of treating. Only a minority of patients can actually afford therapy, standard of care with acute myeloid leukemia. In addition to that, in India, we have a huge problem with multi-drug resistant organisms. And as soon as you give them intensive therapy and they pick up one of these infections, they go from sitting, talking, to ICU in 12 hours and dead in 24 hours. It's very rapid, it's very dramatic, it's quite scary. So we have lots of challenges, and this is across multiple centers. There are many publications of this. Also, in today's age, you will read about a lot of these targeted therapies, and they'll make it sound like this is magic, you have to give midazolam. I think it's good to be a little skeptical and cynical, and also be aware that most of medical education today comes from drug companies, unfortunately. Okay, so let me put this in perspective for you. If I take all these new drugs, including midazolam, there's venetoclax, and I don't expect people who don't deal with AML to know. If I go to a country like Japan, one of the most developed countries in the world, every therapy is based, and drug approval is based on risk benefit and cost benefit for the whole cohort, not for an individual. And so they will make a drug available only if the net benefit for the population is good. Can you guess how many of these drugs are available in Japan? None, including midazolam. The only drug that's approved there in the new drugs is venetoclax. And the bottom line for them is you get them you get an AML into remission and transplant them. And that gives you the best chance of long-term cure. While it's expensive, for those of you who do deal with AMLs, I encourage you to try and induce deep remission, not little bit of ASA, little bit of ven, and keep going. You either treat and with intensity to cure, or there's no point dilly-dallying, because otherwise you're doing expensive palliation. So I'm not going to go through targeted therapies. I'm just going to show you, this is our own CMC data published long back, and our data continues to improve. Just to point out to one fact that, and this is selection bias, and all those factors are there. I don't debate that. But in spite of that, if you're a young, fit patient who has gone through 7-3 and gone through remission, very mature data, there's a 60% chance that you could be cured and alive 10 years later. So I would not compromise on intensity of therapy in a young, fit patient if I could get him into transplant soon after that. So look at some illustrations of where patients don't do well with transplant. And one of them is early relapse in ALL. This is our own data. If you can see this blue graph over here, this is early relapse in ALL. If you take the best therapy, induction, remission, transplant them, the long-term survival is just about 6% to 7%. So it's actually almost futile to transplant an early relapse in ALL, provided they got adequate therapy up front. And this is where CAR T cell therapy comes, and I'll talk about that a little bit later. Not sure why this is not moving. Okay, so the other big move that has happened in transplant, and I think it's all over the country, is haploidentical transplant. I talked about this HLA barrier, but today you don't need a HLA identical brother or sister or a donor. Practically all of us have a haplo donor. Either it's your brother or sister who's 50% match, or your father and mother, if they're alive, will be 50% match, okay? Or even your cousins may be 50% match. So the probability is that everybody sitting in this room is likely to have a donor who's at least a 50% match. There are many caveats which I can't go through in detail, but with a haploidentical transplant with what we call post-transplant cyclophosphamide, the risk of chronic GVHD is quite low, which was a major problem when you had major HLA mismatches. And also, there are some problems, and one of them is high incidence of graft rejection compared to a matched unrelated or a matched sibling donor. So even today, we would prefer a fully matched unrelated donor rather than a haploidentical donor, but it remains an option where there was no other option. Just restricting our data to CMC itself, I'm not going to go through this data in detail, just to tell you in AML patients, for example, who have relapsed and then come to us, and we've taken them through either a MUD or a haplo, there is no difference in overall survival for the entire cohort in terms of haplo or MUD. We also use post-transplant cyclophosphamide as part of a study in matched sibling donors, and we have shown some good data. Dr. Biju George, my colleague, leads the work in bone marrow failure and MUD transplants and in idiopathic bone marrow failure syndromes. He's shown good data with PTCY. We've not changed our practice, but as part of a study using PTCY in aplastic anemia with a peripheral blood stem cell graft in matched sibling donors, we did have good results. Graft manipulation and green therapy, I'm not going to talk a lot about it. I'm just going to say that we have good resources in our center, in our new center as well, GMP facilities, resources to accurately take a graft and manipulate it to get the best out of it. Today, what is happening in the transplant field, the transplant is like the basic template. On that, you can do lots of additional things to improve the outcome of transplant. One of them is, for example, adding NK cells from another donor. NK cells, without getting too much into the biology, can be infused from a haploidentical donor and can act against cancer cells without causing GVHD. Very simply speaking, that's the objective. And my colleague, Dr. Uday, does quite a bit of work in this, and he's actually completed an early phase 2 trial where we've enrolled 14 patients. These are really relapsed refractory patients, who are going to do terribly. So we've just established safety of this, and this we will move to earlier phase trials as we go on. Another major problem, especially as we get into the era of haploidentical transplants, is because of a delay in immune reconstitution, there's much more viral reactivation. And what are the biggest viral reactivations? CMV, adeno, BK. And these are all killers because the drugs are not effective. It's all supportive care. These patients are sick, they have GVHD. And this is where we try and use viral specific T cells. And that can be from the donor, or it could be from another relative who's even haploidentical. So we've standardized this procedure in our lab. So when you generate, and this publication is there, and showing a cost-effective pattern. So viral specific T cells can be generated in two ways. One is all of us have been exposed to CMV. 98% of the Indian population is exposed to CMV. So all of us have inherently some T cells which have previously seen CMV. So if you take in vitro and we do an assay, expose them to the peptide, that is the CMV peptide, those cells will react and produce interferon. And then you can actually pull down those cells in a Milteney prodigy system. And the second way is to expose them to these peptides in vitro and expand those cells. So if you take the cells out and you expand them in the setting of PepMix, which is the CMV peptide, only those cells will proliferate, all the other cells will die. So at the end of 14 days, you will have T cells which are only reacting against CMV, and those cells can be banked and can be stored and infused later. So there are some inclusion-exclusion criteria. I'm not going to go through the procedure. So there are two methods, basically. Cytokine capture system, which is just 12 hours. You take a donor, you identify a donor who has CMV reactive T cells in his blood, and you can actually put it through a machine, and you can pull down those T cells from this donor, and those T cells can be infused into the patient who has a CMV infection to cure him. We can also expand these T cells, and this is also something that we have standardized in our center. And the potential for this is that we can move to creating a bank of CMV reactive T cells. And the advantage of a bank is you don't have to be completely HLA identical. You don't even have to be completely HLA matched. Even if your 1-2 HLA matches, you can create a bank and you can then pull out people who are 1 or HLA matched and infuse it into them. So this is something that we hope to explore as we go through. I encourage you to go through this publication because it goes as a crowded slide. I don't intend to go through this, but these techniques are well established. In fact, it's not that difficult to do. We are in the process of trying to get regulatory approval for this. We've also demonstrated in vitro that these cells work very well. In fact, the cytokine capture system on a preclinical phase, we've treated 6 patients and absolutely safe. Moving forward, we want to create these banks, and that's something that we are looking. And finally, I'll talk about our CAR T cell program. We have started manufacturing CAR T cells in-house, not depending on any industry. Okay, so this is called a well-card study program. And basically, CAR T cells, how can I explain it? It's like taking T cells. Our T cells react to many antigens. Now, you can take a T cell and transduce it with a specific antibody that will react to a particular antigen. So for example, if you want to treat ALL, which expresses CD19 on the surface, you can take a lentiviral vector which expresses CD19, transduce a T cell, so the T cell will now express CD19 receptor on its surface, and you infuse it into the patient. This will now go bind to the leukemia cells because the leukemia cells present CD19, and these T cells will then kill the cancer cell. So that's the principle. So you take the patient's own T cells, you transduce them with the CD19 receptor, and then you infuse it back, and his own T cells will now kill his own leukemia. Fantastic. No GVHD, none of the other issues that are there. So this is really a thing, and worldwide it has made quite a lot of waves, and I'm sure all of you all are kind of read about a little about this. It costs in the US $475,000 for one shot of CAR T cells, $500,000, okay? So this is not something that we can go anywhere near. But these costs are highly inflated. That's because it's entirely industry driven. So what we have done is we have shown that we can do this in an academic center in a fairly minimal setting. So the program that we've got in our academic center, this is data that we have published. We've completed the validation run. The validation data is published, where we can show that we can produce this for less than $25,000, and with some support, we can treat patients. So we have a clinical trial open. We've started enrolling patients. Our second patient is actually receiving the CAR T cells as I speak. And the patients have gone through well. So CMC has always tried to work at how to bring about cost-effective care. Even in 85 or 82, when we started transplant program, it was how can we make transplant program affordable and accessible. If you look back to the start of our program in 1986, patients were going, all Indian patients who could afford it were going abroad for transplants. Today, with all these boys trained over here, nobody in India is going abroad for a transplant. So right now, what's happening, many patients are going outside the country for CAR T cells. In another 10 years, I don't think we will need to do that. So in summary, there are challenges with access to allo-hematopoietic stem cell transplantation in India, and that's something that we all have to work for, how to make any therapy that we have accessible to all. Till we do that, I don't think we can really call ourselves a success story in any way. There are unique challenges to India in terms of how patients present. There can be strategies to how to improve cost-effective strategy in certain settings. Initiation of an allo-hematopoietic stem cell program at a center, a number of beneficial spin-offs for the center. What I mean by that is when Sandeep, Abhijit start transplant programs, not only are they creating a transplant program, they're bringing value additions to that institution by so many other things they touch. The labs have to improve, the virology has to improve, the blood culture, microbiology. So they are putting pressure. So the whole system tends to improve when you start getting into this. We have to reflect at our capacity and capability, and for people starting alone and in single centers, it's extremely challenging. So very happy to see in the centers that I visited that these youngsters have very good administrative support, and that's something that they are very lucky to have. It's not an individual activity. There is no individual glory in this. So I hope Sandeep and Abhijit don't go around saying that they did the transplant. You didn't do the transplant, your team did the transplant. It's always a team effort, and nothing happens alone in transplant. We need supportive administrators, and I've already said that. Thank you for your attention. I'll stop here.
Thank you, Dr. Vikram Mathews, for such a fantastic lecture. Truly, it was very flawless and enriching. Any questions?
Can you highlight about bone marrow transplantation in aplastic anemia? What is your experience?
Yeah, so bone marrow transplant in aplastic anemia is a little bit like thalassemia. It's a common problem in our country. And the biggest problem that we have with aplastic anemia transplants is patients coming in late. So they are diagnosed, then they go around, they pick up multiple infections, and then they come to us for transplant. Very difficult, lots of comorbidities, lots of mortality. But if you transplant, and if you have a good donor for an aplastic anemia, early without infections, your chances of success are well above 90%. So this is again, thank you for asking that question. Many of these diseases, it's so important to refer early and to the right people as early as possible.
Sir, hello. Yeah, so I just had I have a comment. It's nice to listen to you after a long time. Back to basics again. In Marathi, if I can say, like, if science la जर का मूर्तिमंत अवतार जर का घ्यायचा झाला तर he will be Vikram Mathews. So if science has to become a person, he will be Vikram Mathews. Thank you, sir.
Thank you.
A big round of applause for Dr. Vikram Mathews. Thank you, sir.